Afternoon, everyone. It is 11 Central Time, 12 Eastern Time. So we are going to get started here with our a webinar for today. So welcome to the Heterosexual Women and Syphilis webinar hosted by HCET. My name is Megan Arias and I am the training manager at HCET and will be facilitating today's webinar. And let me briefly introduce you to Healthcare Education and Training, or HCET. Our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. And our organization is filled with passionate people who are proactive in their belief that access to evidence-based, medically accurate, reproductive and sexual health education, training, and care is a fundamental right. Next slide. And then this webinar should have closed captionings available, and to enable that on your screen, you will go down to the bottom and click live transcript and then show subtitles. And you can change these settings by clicking the subtitle settings. Next slide. And for more information and to keep up to date with HCET events, please be sure to follow HCET on these various social media platforms and visit our website. Next slide. So now I'll go over some quick housekeeping information. A link to complete an event evaluation will be sent to you in the chat at the end of this webinar, as well as in a follow-up email after the webinar has concluded. And your feedback is greatly appreciated here at HCET. And all archived presentations and a list of upcoming events can be viewed on our website. And if you're having any technical difficulties during this presentation, please contact updates@hcet.org or the email listed on your screen, and they will be able to take care of you from there. Next slide. In order to receive nursing contact hours, a participant must attend the entire webinar, return the completed participant evaluation and the post-test, and to complete the nursing contact hour forms, and then email that to kbradford@hcet.org. Next slide. And the presenter does not disclose any actual, potential, or perceived conflicts of interest. Next slide. And then throughout the presentation, we encourage you to send your questions via the Q&A box. And to submit a question, you're going to hover over the main screen and then select Q&A, the icon at the bottom. And then once that is selected, a Q&A box should appear on your screen. And to send a question at any time during the presentation, just send it through there. This ensures that everyone in the webinar can view your question, and questions can also be sent anonymously if chosen. And we'll hold all questions, reading and answering till the end. Next slide. So now I'd like to introduce our presenter for today's webinar, Dr. Virginia Bowen. Dr. Ginny Bowen is an epidemiologist in the CDC Division of STD Prevention, with an emphasis on the surveillance of adult and congenital syphilis. She joined the division in 2013 as an epidemic intelligence service officer before transitioning into her current role. And her work in the division has included outbreak response, evaluation of novel syphilis tests, programmatic support for antibiotic-resistant gonorrhea detection, and syphilis surveillance. And prior to her work in STDs, she worked in the international family planning. And she received her master's and Doctor of Philosophy degrees in reproductive health at Johns Hopkins School of Public Health. And without further ado, I will pass things over to Dr. Ginny Bowen to kick us off.
Thanks, Megan. Can you hear me? Great. All right. I'm excited to be here today. So good morning and good afternoon, depending on where you're sitting right now in the US or outside the US. I was invited today by HCET to speak about heterosexual women and syphilis. And it's a really exciting topic. And obviously, I'm struck by the fact that somebody came to HCET and actually asked, can we get some content on this topic, which is really exciting. HCET, when I first started to speak with them, said, typically we service a group of providers and health department professionals who are mostly located in the Midwest. And they gave me some background about the organization. And then when I saw the registration list last week, it looks like we have a very national audience today at the the webinar. So hopefully I can provide a little bit of content that feels relevant to all of you. Before we get started, I just want to put out a little disclaimer, which is to say the presentation today is really about women and syphilis. So if you're here today solely to hear about this piece, this heterosexual piece, I hope you're not going to leave disappointed with me. I want to explain a little bit about why that is, though. So I titled this slide, "Why Can't CDC Tell Me Definitively That We're Talking About Heterosexual Women?" The truth is that we do collect some information on this topic. At least in theory, we do. We aim high. We added 2 variables in 2018 to the case notifications. And these 2 variables focus on sexual orientation and gender identity. And if you've ever worked at a health department and you've seen the way these variables are collected and transmitted to CDC, you might laugh a little bit, especially if you work in sexual health for the majority of your day. These were not necessarily crafted by us. These are OMB compliant ways of collecting information about sexual orientation and gender identity. But the truth is, these are actually optional data elements. And so to submit a case of syphilis to CDC, you don't have to fill out these data elements. In fact, 71% of all of the women with syphilis that we know about at CDC for 2019 either were not asked about their sexual orientation, or the information could not be stored in a local data system and transmitted to us, which might be more of like an infrastructure issue. So we have some limitations in being able to talk about sexual orientation among women in particular. There is another older variable that we've collected for a long time, which is sex of sex partners. And the way that that's collected is if I'm sitting down and interviewing a case of syphilis, or excuse me, interviewing a woman who has syphilis, I would say, have you had sex with males in the past 12 months? Have you had sex with females in the past 12 months? And then I would use the answers to those 2 questions to try to triangulate some information. But the reality is 33% of our case reports are missing information there as well. But when we restrict to states that are sending us complete data, and we measure that and say 70% complete, we really find that about 5% of all of the women reported with syphilis are having sex with women. The vast majority of those women are having sex with men also, but there are some women out there that are having exclusive sex with women and being reported as cases of syphilis per the case reports. So I say all that because I'm leading up to this disclaimer, which is to say the remainder of this presentation is going to focus on women collectively, and it's not going to distinguish by the sex of their sex partners or their stated sexual orientation because of the limitations of the data, and I hope you understand that. I'm trying something new with today's presentation. I'm actually going to reverse the order in which we talk about these things. So normally I would start off with a really broad introduction to syphilis, like let's talk about the bacteria. And I think we'll get to that. But I really want to start more with like, why is this important? Why are we talking about this now today? So I hope you'll bear with me that we're going to talk broadly about syphilis first before we dig deep into, what is syphilis clinically. And again, I know that many folks on the line are clinical providers. I think probably 30 to 40% of registrants had some clinical management role, but I know a lot of you are not, and you are coming from a different space. So that's why I wanted to try this reverse ordering. We'll see how it goes. The first thing I want to touch on is kind of where are we going when it comes to syphilis among women, and how do we get off this bus? I think you can already tell this is not a bus we want to be on. So I'm pretty sure heterosexual syphilis is a topic of interest for many providers in the Midwest, because in our 2019 surveillance report, we announced that we have almost 130,000 cases of syphilis reported in the year of 2019, which represents a 74% increase in a 5-year period. So that is a very high, very fast increase in syphilis, and it has been steady for 6 years now. So this just shows you a 5-year snippet. I think that's why I was invited to come and speak today. So I think you can hopefully see from the onset that we're not in a great place right now. But really, what I think is the most interesting story, if you've even peeked at our 2019 surveillance report, you may not have taken this message away immediately. You saw the other infographic, which just says syphilis is going up. This is alarming. But really the lead, I think, is kind of buried in the surveillance report. Somewhere on slide 37 or 40, you will find this detail right here, this little nugget that you see on your screen, which really shows me that not all syphilis increases are created equal. What we see among men who have sex with men, which is the burgundy line at the top, is not necessarily what we're seeing among a heterosexual population, the women at the bottom and the men who have sex with women, or MSW. So really what I see here is that we have almost a flatlining epidemic or increase, a flatlining increase among men who have sex with men, but a continuous increase, perhaps an increasing slope even, picking up speed among our heterosexual populations. And if you work at a local jurisdiction level, you might be able to see this in even greater detail when you look at your data, right? I just showed you national data, but if you looked at your data, this might be even more stark. So I want to give you an example. I had a jurisdiction reach out to me just a month ago and say, we think we want to declare an outbreak of syphilis. We are seeing a 9% increase in early syphilis across the state, both sexes, between 2019 and 2020. And that's taking into account, COVID. Can you even imagine what it looks like now? And that was certainly compelling. But the first thing I said to them, because I knew about this national trend, I said to them, why don't you take a look at this by sex first to see if this is really an increase across every group, or whether this is more specific, perhaps to a heterosexual population. So the first thing they did was to come back a week later and say, well, you were right. It kind of looks like this is a really big increase among women and a slight decrease among men. So this 9% increase that we saw at the state level is masking two groups that are actually moving in different directions. Huge increase in women over the year and a much smaller decrease in men. And I said, I'd really strongly encourage you to stratify one more time and look at those men more closely. And they did it. And what they found was, in fact, much like the national picture, there was actually a 31% decrease in syphilis, early syphilis, among men who have sex with men, while at the exact same moment in time, a 41% increase in women. And put together, those two curves were producing this statewide average of a 9% increase. And I said, if you're going to declare an outbreak, that's the message that you lead with. It's not that we've got a statewide outbreak of syphilis. It's that we really have an outbreak of syphilis among women. And maybe you could expand it to say among heterosexual populations or people who have sex with women also. Really to just kind of hit the point home, nationally, we know that this increase in syphilis among women is occurring across all age groups. Right now, the highest incidence is among 25 to 29-year-old women, very closely followed by 20 to 24-year-old women. But really, we're seeing these increases everywhere. And I'm going to go back for just a moment. I don't have a slide that speaks to this specifically, but I think it's important to share that we are seeing increases also across all racial and ethnic groups at the same time. So this is not just affecting one group of women, one region. This is everyone, everywhere. I want to hit home something that I find super interesting, which is that syphilis, which we used to think of as a concentrated problem in urban areas and the US South, has actually become a very diffuse problem. So we are seeing this spread into places that syphilis has not been in a long time or ever. And to really show that here, I've put two maps side by side. In the first map on the left from 2010, I don't think you can see this exactly, but I'm going to tell you 27% of all counties are lit up in that map in 2010. They're colored purple because they reported at least one case of syphilis among a woman of reproductive age. By 2019, basically 10 years later, we were seeing 50% of all counties light up with a signal that says there is syphilis here among women. And I think most of you know this, but when there's syphilis among women, there's risk for congenital syphilis as well as transmission sexually. So I wanted to share some slides that were graciously provided to me by the Indiana Health Department. Again, HCET normally services a provider audience that is very Midwestern in nature. I want to just echo that this is exactly what Indiana is seeing as well. They are seeing increases. This is actually cases among women. But if I move on, you'll see they were able to break their data down by sexual orientation. And you have to understand these words at the bottom, gay and straight. They're not words that are chosen by Indiana. Like I mentioned earlier, these are words that are chosen by the Office of Management and Budget. So you have to bear with us here, but we've got a heterosexual or straight population seeing a 32% increase in that orange line, and then a gay, bisexual, or other population seeing increases as well in the blue line. And they are also seeing increases across all races and ethnicities. So I share this data really just to say, this is something that I think many jurisdictions are grappling with right now. If you sit in a state that is not seeing increases in women and multiple groups of women, I would be surprised. So the next question we always get at CDC after explaining the, here's where we are, is why? Why are we headed in this direction? What have we done? What has changed in the past 10 years to lead us here? And to be truthful, I don't have a great answer for that. I think that there are many stories across the nation that have contributed to these increases. I think in some places in the South, there are very disenfranchised groups of people that are having trouble accessing the healthcare system. And I think in some parts of the West and Midwest, we are seeing really sharp increases right now in high-risk behaviors like drug use. So I don't have a perfect answer to the question. I'm just going to tell you a little bit of the story today, which is we have just finished evaluating the 2019, what we call the behavior data, the risk behavior data among cases reported to us. So again, only among the women that have been reported to us as cases of syphilis, we are seeing stark increases right now in methamphetamine use, which is the blue line at the top here. We are seeing pretty solid increases in people reporting that they have had sex with a person who injects drugs in the past 12 months. We're even seeing increases in individual injection drug use and specifically some heroin use. Heroin use, you could argue, may be flatlining, but it's a little early to say. Heroin use, just to be fair, over the past 5 years has still doubled from a 3.5% report rate to a 7% report rate. So it is certainly creeping up. But really what's stark here is the fact that in 2019, 22% of our syphilis cases among women self-reported methamphetamine use, which says a lot. There is obviously bias there probably, and people may be inclined to underreport their methamphetamine use. So this could be even higher in reality, is the story. I want to go into just 2 of those risk behaviors a little bit more deeply. One is injection drug use and one is meth use. Starting here with injection drug use, I really just want to show you that women are reporting more injection drug use on a percentage basis, right? Obviously, more of our cases are male, so take that into consideration. But among the women being reported as cases of syphilis, more of them are self-reporting injection drug use behaviors. So I think you can see my mouse, I hope, I'm not sure. Take a look at the purple line up here at the top and really compare that against the golden dashed line down here for men who have sex with men. And I think you'll find it kind of staggering, not only that women are so much higher, but that these MSM, again, have kind of steady, flatlined behavioral characteristics while women are reporting riskier behaviors over time. So that could be a piece of this story as to why more women perhaps are being reported as syphilis cases. This is just to show you some regional differences. I want you to see, because again, some of you are sitting in the Midwest right now, which is where this kind of webinar series was originally tailored to focus. I want you to see that the Midwest is seeing a very stark increase right now in cases reporting injection drug use. But that's not to say that everyone else isn't also seeing increases too. I want to jump to methamphetamine use and just show you similar slides here, which is to say, once again, women are reporting higher levels of this particular behavior relative to their MSW counterparts and relative to their MSM counterparts. So that is similar to the injection drug use slide I showed you earlier. And we're also seeing similar patterns here where we've had some increases in the Midwest and the South that kind of draw our attention and our eyes. So I think I want to move into the next section, which is not necessarily what's happening, what's the landscape. I think we've covered that a bit, but what do we do about it? Like, what now? And so I've titled this portion of the presentation, If I Can't Get Off the Bus, How Can I at least slow it down? And hopefully many of you might be my contemporaries out there. I'm not sure. I might have more gray hair than some of you, but hopefully this brings back a reference for you to the 1994 action thriller Speed with Keanu Reeves, where we're on a bus literally, and we can't slow it down. We are going to be in big trouble if we slow it down, but man, we got to find a way. So without further ado, let's talk about the basics of how we might be able to reverse course on syphilis among women. This is going to sound super basic and very pedantic, but I want to go back to the basics here, which is if you've ever been trained in a school of public health, you know that there are two forms of prevention. There is primary prevention, which is really designed to avert disease before it even happens, right? How do I prevent a woman from getting syphilis in the first place? So I've labeled these two activities as primary prevention activities. Consistent, proper condom use, basically barrier method use is kind of a broader bucket there. And then behavior change, which is I need to convince people somehow to have less sex or fewer partners or fewer concurrent partners. Both of these really feed into the idea of that Anderson-May kind of transmission equation. The best way to reduce syphilis is to limit people's duration of infection and to limit people's exposure through sex. So that's primary prevention. That's how I'm going to prevent a lot of women from getting syphilis. I'll be super honest and say, for a while at CDC, and I've been here 8 years, for a while at CDC, these messages have not been super popular. We have not been out there running giant condom campaigns as a division of STD prevention because these messages just didn't resonate very well. But I will say, as this epidemic shifts a bit more from an MSM epidemic into a heterosexual epidemic, we have done focus groups and found that these messages do resonate a little bit more with women. And so, believe it or not, we have new messaging material, that we put out for others to use, like health departments to use when it comes to primary prevention. How do we get these messages of condom use and partnership out there to people? So I just want to give you an example here of some of the messages that CDC has created and posted publicly on our website for anyone to use, which is just to say STDs are out there. They still happen. They're actually increasing. But you have agency as a woman and can do something about this. This does not specifically target women, but I think you can see it was informed by work with women. So this is primary prevention. But really what a lot of our energy is spent on, because it's hard to change people's behaviors. It's really hard to change people's behaviors, whether that's condom use or partnerships. We spend a lot of energy on this other type of prevention, which I'm bucketing here as secondary prevention. So again, you probably learned in a public health class at some point that secondary prevention means I may not be able to prevent your syphilis, but I can at least find your syphilis quickly and clamp down on it by treating it so that I can reduce your sequelae and reduce your transmission in the community. So really the objective with secondary prevention here is I'm not going to give up on primary prevention, but I want to strengthen the portfolio of work around finding and treating cases quickly. And so the next question that a health department is going to ask me, I'm sure, is where do I find people with syphilis, especially women with syphilis, reliably? And the answer is, the number one case finding activity for women continues to be partner services. And I say that because if you interview a man who admits to having sex with women, and you find those women and test and treat them, they have a very high likelihood of coming back positive for syphilis if he had an infectious case, right? So syphilis is highly transmissible, especially during primary and secondary stages. So partner services continues to be the number one yielding case finding activity. But it's hard sometimes to find men who have sex with women and to get them to name partners and then to close that loop, right? But I want to highlight that that's still the highest yielding activity out there. But there are other activities that I want to make sure we advertise broadly. There's another way to focus your efforts, which is to screen people, not just focus on people with symptoms, but to broadly screen people with a higher than average risk for having syphilis. Where might you do that? Well, some of the epidemiology we have seen from local jurisdictions points to incarcerated populations and populations of people that are somewhat disenfranchised from the health system who use emergency departments as primary care. So these are two different groups, jail screening and emergency department screening, that have shown in the literature to be fairly high yield places in this day and age. And I want to come back and talk about the specifics on that in a minute. Another way to focus your screening efforts is to say, well, maybe I don't care so much about finding the highest yield of women with syphilis. I want to find the ones where the outcomes are really devastating. Maybe I want to focus my efforts on preventing devastating outcomes. And that's where you would turn towards improving or ramping up your prenatal screening efforts, because congenital syphilis is, I think, undoubtedly one of the most devastating outcomes of syphilis among women in terms of, downstream events. So screening people where outcomes are really bad is a little different than screening people where I expect to find high case yield. And then to close this loop of secondary prevention really tightly, you really have to improve the way that you treat people who test positive. How much involvement does the provider have, and how much involvement does the health department have to get that treatment loop closed as quickly as possible? I want to expand. I said I was going to expand a little more on jail screening and emergency department screening because they are very hot topics right now. Before I do that, though, I want to make the point here that partner services is the way that we have really focused on this in the past, because like I said, it is the #1 highest yield case finding activity. I am more likely to have a high % positivity if I test women who are known sex partners of men with syphilis. But that said, as case volume in the US for women has crept up and up and up over the years, we have not had an influx of, magical disease intervention specialist or DIS money in the past to keep up with this volume. So the volume of cases has gone up and up and up, and our ability to actually intervene and close the loop and get those women tested and treated has gone down over time. And I know the data is a little bit outdated, but this used to be a performance measure of ours at CDC. And it's not exactly a performance measure anymore, so I don't have better, newer data. The good news is, and this is not a secret I'm sharing, this is very publicly available information. We have received a large influx of money this year, has not gone out the door yet, but it's headed out the door, to focus our efforts once again on reinforcing the disease intervention workforce. And one way to do that is to get people kind of back to the basics of doing syphilis work, disease intervention work specifically around syphilis. So that's the thing I wanted to say before we go on to talk about emergency department screening and jail screening. So I've lumped these two together. They might seem really different to you, but to me, they are both a very specific kind of venue-based screening. So what kind of places can I go to and implement screening programs in a place where I believe a lot of people might have a high risk of syphilis or high prevalence of syphilis? And emergency departments have come up several times, and people are reinvigorating their interest in ED screening for syphilis. I have met with executives, hospital executives, to talk about this topic. And I get the same 3 questions each time, which is, what are the parameters I should use? If I'm going to set up a screening program in my emergency department, who do I test? Who gets offered a test? So that's question #1 that has to be answered, is how to draw those parameters. Some people take a really broad approach, which is to say, since I don't know exactly where to draw my parameters, I'm going to, for a limited amount of time, maybe a couple months, I'm going to test everyone. And I'm just going to see what I find. And I'm going to see who in this community is most likely to have syphilis. And then you can tailor your parameters, and maybe you find that it's 15 to 44-year-olds or people from, this, that, or the other neighborhood. But here the idea is you have to define some parameters. Other people have chosen an algorithmic approach, which is to say, if my EHR tells me that this person is under the age of 50, presenting with one of the following 7 symptoms, and reports a history of STDs, I'm going to offer them a screening test. And that's also another approach, but I would say it's a little bit more limited in terms of picking up these new concerning cases that we're seeing right now. But that's question 1, define your parameters. Number 2 is who will pay for these tests. The first thing I always get, especially from the hospital management side, is this is not directly related to the clinical care that I need to offer that woman who came in here today for a broken ankle. How do I justify this test and who's going to pay for it? And the truth is that these are often, we don't often see, we at least at CDC have not received any evidence to date that insurance providers are clamping down on the offering of syphilis tests. So yes, there's usually some way in which this is tied into clinical management. In the rare instances where you can't make a successful case for billing someone for a syphilis test, is there a way for the health department or a private foundation to step in and cover these costs? So that's something to grapple with. We do find that HIV screening programs, many of them in the United States, are supported by private foundations. So let me say that again. Emergency department HIV screening programs in many locations in the US are supported by foundations, particularly pharmaceutical affiliated foundations, for example. So that's a very interesting concept. We don't have that in our back pocket, unfortunately, in the STD world. So we have to be creative. And then lastly, who will follow up on all these newly generated positive results? That is a concern. If you're a busy emergency department and you're now generating 4 times more syphilis positives than you've ever had before, do you have the nursing support to not only relay those results, but get people in for follow-up care? Or could the health department step in that very specific role and be your new helper and friend? And I think that is a creative way to think about some of this new disease intervention money that is kind of coming down the pipe. The second thing I want to move on to quickly is just jail screening. Some of the questions that you ask yourself when you're setting up a jail screening program are pretty much the same. I would argue on the who will pay for these tests, there are 2 camps there. One is that, the correctional side of the system pays for this because it's considered part of clinical care, and incarcerated persons are due clinical care. But I would say a screening program is a little bit different than a testing program, right? When someone presents with symptoms of syphilis, surely, yes, we all agree that the correctional system can pick up those costs. It is a little bit of a quandary, though, when we're talking about expanding a screening program to people that don't all have symptoms. And so the health department may need to be prepared to step in and cover some of these costs. And then there are really logistical nitty-gritty questions about when to test and, again, how to follow up. I want to refer you to 2 good papers on this. The first one is about jail screening, a very lovely paper written out of Fresno, California, found very high case finding rates in their local county jail. And they implemented a full-blown screening program, not a testing program where you had to have symptoms, but a true screening program. And they found among women something like a 7%, prevalence, which I thought was fantastic. And then the second paper here is an ED screening paper. So I'm going to move on, and I want to get into the clinical space with the time I have remaining. I think I've got about 12 to 15 minutes to talk kind of backwards. If you are a clinical provider and you're saying, that was great, Jenny, that was really all focused on the health department and where health departments should be headed to combat syphilis among women, what can I do as a private provider or even an STD clinic provider to take action? I hope today's training kind of improves your ability to recognize, diagnose, and manage syphilis. So that's the aim of this next 10 to 15 minutes. Briefly, I want to talk about how we actually diagnose syphilis. So there are 2 main methods for diagnosing syphilis, or 2 buckets. Let me just say that, 2 categories or buckets. And this might be a repeat or a refresher for a lot of you, so I apologize. But to those of you that might be new to syphilis, it's totally worth saying that there is direct detection, which means I am looking for the bug itself. And the bug here in this case is Treponema pallidum. I am looking for the bug itself, or I'm looking for direct evidence that the bug is in this person by looking for genetic material, PCR, like a gnat, for example. So that is what we call direct detection. I want you to know, if you're new to syphilis, that is extremely rare. It is extremely, extremely rare that you will have access to direct detection methods, unless you work in a great academic center or a very large health department. You will probably not have a dark field microscope or great access to PCR. So typically these would be done by swabbing lesions and, sending them off for direct detection testing. It's not common. I think probably among all of our case reports, fewer than 10%, surely, of all of our syphilis cases are confirmed cases where direct detection was performed. So the vast majority of all of our syphilis testing in the US is done through serologic testing, which is that other second big bucket. I want to give a really simple primer on serologic testing to get us maybe on the same page here. So I'm going to start with just talking about what antibodies are. And forgive me if you're an ID doc out there and I'm forcing you to sit through this for a second. But for everybody else, including me, not a doc, when the body recognizes a new bug, bacteria, in this case, Treponema pallidum, it will defend itself by creating antibodies that are unique to that bug. And this cartoon I picked, I like it because it specifically shows you right here what that antibody looks like, right? It's the little Y-shaped prong that this, white blood cell is chucking over here at a bacteria. So our body is creating antibodies in response to T. pallidum once we've been infected. And serologic testing for syphilis, I'm not looking for T. pallidum anymore. I am now looking for those antibodies. That's actually what I'm trying to pick up on. But just like with chickenpox, which many of us are familiar with, again, if you were born in the 80s like I was, you know that you're going to carry those antibodies theoretically for life. And syphilis is the same way. You build an antibody and your body has a memory that is just sharp, and you keep those antibodies for a long time after you've been infected. In fact, 85% of people that have been infected with syphilis are going to have a lifetime response to treponemal testing because of this, right? So that creates a problem for us. If I don't know if this antibody in your blood is old and reflective of an infection that you had 10 years ago versus an infection that you got last week, I'm in trouble. So thank goodness we have really smart scientists years ago, decades ago, that discovered you can actually detect a second antibody. So in order to tease apart old syphilis from new syphilis, I'm out there now, not just looking for the one antibody to T. pallidum, but I'm out there looking for a second antibody that we can test for. And this second type of antibody is called nonspecific. And it simply tells us if the body is currently, at that moment, presently under attack. And it's basically an inflammatory marker. So I really think it's important that you walk away today understanding that people diagnosed with syphilis need to have both of these two distinct types of tests, right? You need to have a treponemal test, but then in order to figure out if this is a current infection, not just historical, you really need to have that non-treponemal test also. So I have, again, the slides, you're going to take these home and hopefully use them as a reference in the future. These slides will remind you, I hope, that you need to have both test types for most diagnoses of syphilis. And I've given you some examples here. In particular, it's important to know that TPPA and EIA are treponemal tests. And then the acronyms RPR and VDRL, those are non-treponemal tests. Now, our non-treponemal tests are even more sophisticated than that, and they're quantitative tests. So you'll actually get a measurement that shows me how much antibody or inflammation is in this person's body. And it's important to get those quantitative results so that you can monitor treatment response in particular. All right, so moving on, just to hit it home real hard, most stages of syphilis are going to require a positive result in both categories to diagnose somebody as having syphilis. Oops, sorry here. The only exception to that is primary syphilis. And the reason for that is because it takes the body a little while to mount an immune response to syphilis. And we don't expect that everyone with primary syphilis is going to show up positive on both tests. So for primary syphilis, if you see symptoms of primary syphilis, signs of primary syphilis, it's okay to just have one positive test result and to call somebody a case of syphilis. And for those of you that love a good graph, this is to kind of show you why that is, right? Antibody responses take a little while to develop. So over here on the x-axis at time 0, this is when the person is actually infected with the bug. But you can see that we don't get a good response on antibodies. And here, again, these two lines represent some classic treponemal tests. And these two lines represent some classic non-treponemal tests. We're not getting a really good response on antibodies till 10 weeks, 12 weeks after infection. And for that reason alone, primary syphilis may not trigger positive results on both tests. Keep it in mind. All I want to say is different hospital systems or different practices are going to utilize two different algorithms for syphilis testing. They are both valid approaches to testing somebody for syphilis. One of them we call traditional, which means leading with a non-treponemal test and following it up with a trep. The other one we call reverse sequence, and it involves leading. I don't know if I said that correctly last time, just to clarify. The traditional leads with a non-trep, and the reverse leads with a treponemal test. In this case, usually a large-scale automated platform like an EIA or a CIA, and that's for cost-saving measures, and then follows it up with a non-trep, and then to adjudicate that, possibly even a third test, another treponemal test. I'm going to skip over some of that for just a moment. I want to get to clinical stage questions I want to get to some of the signs very quickly so that if this is a new topic for you, you walk away with a few images that you can keep in mind as you approach your differential diagnosis in the future. So the primary syphilis stage is characterized by this chancre or lesion. And in the past, most providers have been taught that it is one chancre in one location, which is where the bacteria entered the body. I want to dispel that myth just a little bit. It's actually, it's not 100% true that you're going to have one chancre. In fact, 25% of people will present with more than one chancre on the body. And that is more common in persons that are immune compromised. We've also been taught for a long time that those syphilis chancres are painless because the bacteria has attacked the nerves in that area. And that's true. They're typically painless, but they can sometimes be painful. So don't let that fool you. These will resolve on their own without treatment. And that's why a lot of people, don't even notice that they had a chancre, right? It's somewhere not visible to them, like perhaps inside the vagina or inside the rectum. And then it goes away on its own and it was never painful in the first place. And so these can go missed very often. Oh, goodness, sorry about this. This apparently has some animation. Let me just show you some images. These are very classic primary chancre lesions. This one right here is called a kissing lesion because the bacteria entered in one part of the labia and then touched the other part and transmitted, kind of self-inoculated. I want to move on though, and you guys again have the slides to peruse at your leisure. You can take a look at the lesions later and certainly ask me questions about them if you'd like. But I want you to be able to also recognize secondary syphilis, which is typically the stage that follows primary. It includes rash, mucus patches, condyloma lata, but also systemic symptoms, lymphadenopathy, anorexia, etc. They're all listed here. These secondary symptoms can last a while, and it is possible, believe it or not, for somebody to still have evidence of their primary lesion when their secondary symptoms start to develop. So be on the lookout for that. Titers are their highest during secondary syphilis, which means this person with secondary syphilis is super infectious, both to a sexual partner and to a fetus if they happen to be pregnant. This is their most infectious stage right here. We've got to identify secondary syphilis really quickly and take it very seriously. I would say the same for all syphilis, but I have to hit that point home for secondary. And these are, again, some of the pictures that you might expect. This is a very classic palmar plantar rash here. It's a healing rash on this person, which is why it looks a little bit scabbed over. You shouldn't expect it to look like that always. There are not a lot of bacteria that cause, or there are not a lot of infectious agents that cause this characteristic palmar and plantar rash. So when you see this, you should really think syphilis. And these are condyloma lata. And I'm just going to scoot on quickly because I don't want to run out of time for Q&A. And I want to say these are the most infectious stages. If you're finding a lot of this in your community, you're at the leading edge of a new epidemic, and you need to act quickly, both at the provider level and the health department level. But there's also latent syphilis, which we typically only detect through our screening procedures, right? So screening remains very important because syphilis does self-resolve and disappear into this latent stage, even within the first year. So we typically categorize latency as being early, meaning within the past year, or late. And you will also clinically hear the term tertiary syphilis. We don't use this term much at the health department level, but clinically you might hear about tertiary syphilis, and I'm not going to talk about that today. I just want to say a few quick things that I find to be super intriguing about syphilis that are maybe not always in your textbook in medical school. Fun fact, I call it fun fact, not very fun. Fun fact number one is that people can move back and forth between stages. This does not always progress linearly. In fact, it's common for some people to go all the way to latency and then move back into secondary for a second time within an infection. It's also interesting to me that people with a history of syphilis are more likely to skip over the stage of primary and go straight to secondary syphilis when they get reinfected, right? So somebody with a history of syphilis may come into your office with a rash, and that might be a very recent infection if they've had a history of syphilis in the past. And then fun fact number three, this is a good reminder for health departments and clinicians, neuro, ocular, and otic, meaning ear symptoms, can occur at any stage. This is not something that exclusively happens within tertiary syphilis. You can have somebody with secondary syphilis who's also having vision problems. You can have somebody with secondary syphilis who's also got, CSF involvement, for example. So those are really important things to keep in mind. Is neuro is not just something that happens to people that have been infected for 10, 20 years. In our world, in CDC world, we have two different sets of language. We have clinical language, which is kind of what I've used just a minute ago in our presentation. I want to recognize and acknowledge that we also have surveillance language that matches up with these clinical stages. And so this slide is just to kind of remind you that we speak slightly different terms, but we usually can get on the same page relatively quickly here. Primary is primary, secondary is secondary. On the health department side, we use the term early non-primary, non-secondary to talk about an early latent infection that has no characteristics of primary and secondary syphilis. All right, the one thing I want to hit here, and then I'm going to probably go ahead and pause for questions after this. I have found in a lot of my work with providers and disease investigators, both groups of people, that we struggle a little bit with staging latent syphilis. So syphilis with no symptoms of primary and secondary. And we struggle because we have those two categories, early and late, but we don't know exactly what it takes to qualify someone for either of those boxes. So I want to review those criteria with you today before we pause. I want to start by saying my general approach is if someone presents with no symptoms currently of primary and secondary syphilis, you need to go ahead and default them. Think about them as a case of unknown duration or late syphilis, unless you have good evidence that they have acquired that infection recently, meaning within the past 12 months. So think about the default being unknown duration or late. Now, here's how that generally works. You have cases that you are reviewing and trying to stage appropriately if you're at the health department level. If they have no signs, but they have a positive treponemal and non-treponemal test, you need to start by putting them in this box of unknown or late. And then as you are able to identify evidence that they are actually an early case, you can move them out of this box and reassign them to a 730, right? That's what we call it in health department speak. You can reassign them to a 730 after you found your evidence that you needed. And here are some pieces of evidence. These are for use by health departments and clinicians. You need one of these pieces of evidence in order to call somebody an early case. This person either needs to tell you that they have experienced sexual debut, which is a fancy way of saying they've lost their virginity within the past 12 months, or you need to find that they have seroconverted from a non-reactive to a reactive test in the past 12 months, or they've got symptoms, they've self-reported that they have had symptoms of primary or secondary syphilis in the past 12 months, or you know that their sex partner has, in the past 12 months, has been diagnosed with primary, secondary, or early latent ENPNS syphilis, or this person, perhaps they've had a history of syphilis in the past, you know that they've seen a fourfold titer increase in the past 12 months. So these are all kind of things that you can use as evidence to prove that this infection is in fact early. And it's important to remember because when somebody, I'm gonna skip this for a moment, when somebody has early syphilis, we treat them with 1 dose of penicillin. When somebody has early syphilis, meaning primary, secondary, or early latent syphilis, we treat them with 1 dose of penicillin. But when somebody cannot be proven as early and we default them into that unknown duration or late box, they actually need 3 doses of penicillin spaced apart at 7-day intervals. And I'm going to just put 2 more notes on the page. These are really oriented towards clinicians that might be listening right now. It's very important that you actually get a non-treponemal test titer. In this case, I said RPR. Get an RPR on the day of treatment because you're going to need that to monitor response to therapy. And then the other thing I would say is bear in mind that if you miss that 7-day spacing mark, you are at jeopardy, of having to restart the entire series. So we really do want to emphasize that if somebody's treatments doses are spaced apart by more than 9 days, you absolutely have to restart therapy. So that is kind of the message to hit home today. Megan, I think I'm going to stop here because I'm over time on the presentation and I want to leave 10 minutes for Q&A. So I'm going to turn it back over to you, I think, and tell me if you want me to stop sharing slides right now.
Yeah, you could stop sharing for now. Thank you so much. And to submit a question, again, you can use either the Q&A at the bottom as well as through chat, whichever you're more comfortable with. I will just start off with one of the first questions we have is, now that things are opening up, when will the CDC begin in-person partner services instruction?
That is a great question, Lori. I don't have a good answer for you today, but I can try to find out from, we have a branch here. It's, I will say our staff members are usually not the ones actually in the field offering these, what are called passport to partner services trainings. We contract out this work usually to a training center that then operates and runs DIS training programs all across the nation. So it's kind of a third-party organization, but I need to find out. It's a great question. I need to find out when in-person trainings will get back up and running again. I don't know the answer.
Thank you. Another question we have is, you talked about non-treponema tests showing current infection, but what about patients who serofast at a lower tier? I'm sorry.
No, I'm trying to find it, Megan. Is it in the chat box? I can try to read it.
It is in the chat, yep.
Okay, so Katie Haringa writes, we talked about non-treponemal tests showing evidence of a current infection. It is true that that test result for some people can stay positive for a while. Like there are some people that do not serorevert or go back to non-reactive for a long time. And some of you that practice might say, I have patients that appear that they'll never go back to seronegative again. It's a great point. I don't know exactly how to respond to the question other than to say, you're right. Somebody can stay positive on a non-trep for a while. If you have one of those patients in your care, it's really incumbent, to do regular non-treponemal testing on that person so that you can keep an eye on that titer and monitor it for changes. A change in that titer, if somebody has consistently been low but positive at a 1 to 2 for a year and a half, and then they jump to a 1 to 8 or a 1 to 16, that's a flag that should be acted upon. I mean, that's concerning. And I think if you have a serofast patient and you know it, that's kind of what you're on the lookout for at that point.
Thank you. And then Sheila asks, if patients can go back to having symptoms after having latent syphilis, then shouldn't they always get 3 doses of Bicillin?
Bicillin, that's all right. Nope,
Bicillin.
you're good, you're good, you're good. You're doing great.
If there isn't any serologic proof of negative results within the past 12 months.
I'm gonna see if I can understand that, Sheila. I might need to come back to this as opposed to answering this one on the fly. If patients can go back to having symptoms, and we talked about how sometimes this is not a linear progression. People can enter the early latency period and then show signs of secondary again at some point. Usually that back and forth movement usually does happen during the first year of infection. So we typically still consider those people to be good candidates for 1 dose of Bicillin. But I will punt this to our clinical team and try to get you a better response, Sheila. I can circle back and put this in like an FAQ that's shared by Megan.
Thank you. Another question in the Q&A is, interesting that MSM seems to show a decline in cases, but not true for hetero cases. How are you successful in doing that for MSM cases, but not FSM cases?
That's a great question. I mean, we are really good at CDC at describing what is happening, but not having all the details to be able to explain why it's happening. So when we saw this flatlining of the MSM curve this past year, it was a strengthened feeling. We initially saw it in 2018 and we said, ooh, we should watch this. This might be a blip. And then when it happened again in 2019 and it really did look like it was leveling off, we said, this is something we should take more seriously. What's causing it? And like, we don't have great data to explain how that's been achieved. We have speculation, and I'm sure you guys in the field have speculation. I mean, one of the things we speculate is that maybe PrEP guidance, PrEP implementation guidelines have really been taken up by providers who are serving a primarily MSM population. So those guidelines specifically state that men who are good candidates for PrEP need to be screened for STDs more frequently. In fact, twice a year to 4 times a year. They need to be screened for STDs if they are taking PrEP. And that has to do with the fact that they may be changing their behavior as a result of their PrEP. And, perhaps behavioral disinhibition, studies have shown that they may be using fewer condoms, maybe at higher risk for syphilis. So let's at least detect it quickly and stamp it out with some treatment. So there is a chance that PrEP guidelines may have something to do with the flattening of the MSM curve. There may be other things out there, and I'd be happy to have you guys pitch ideas into the chat box if you want. That's my leading suspicion right now, but I don't have a great answer.
Thank you. Katrina asks, in congenital syphilis cases, if the mother is treated adequately during pregnancy and likelihood of reinfection has been ruled out, how likely is it that the infant would still present with evidence of a congenital syphilis, such as long bone lesions?
Okay. Sorry, Megan, is that in the Q&A box?
Yep.
Okay. I just want to read that with my eyes. I lost it for a second. How likely is it? It's not. So this person, Katrina, has a really good grasp on our congenital syphilis definition. For those of you that don't have as strong a grasp on it, there are 2 parts to congenital syphilis. You can be a case of congenital syphilis because your mom had syphilis and was inadequately treated or not treated at all. Or you can, independently of your mother, you can at birth show signs of congenital syphilis and have a positive RPR yourself. And so I think Katrina is asking, how common is it really that babies are in that second bucket, what we call the infant criteria? Katrina, you'd be surprised, I guess. I would say probably 25 to 30% of the cases that we see at CDC, at least what we can see on the case report form, does indicate that these babies have an independent process going on. We have some suspicions, obviously, that is more common in a situation where mom had secondary syphilis, more of those breakthrough cases where babies still show up at birth with signs and symptoms that are concerning, even though mom on paper was adequately treated 30 days before delivery. So more common to see in secondary syphilis, but it can happen in other stages. And again, this has something to do with the data that we get at CDC. We don't collect perfect information on how everyone else in the nation is measuring adequate treatment. So there is a possibility that there's some variability there. And what we call adequate treatment is not what Dr. Smith sitting in Wyoming calls adequate treatment, you know? So there is some, it's hard to answer, is the answer.
Thank you, Dr. Bowen. And due to time, that is all the questions we'll have to answer today, but I will save the questions and send them over to you if you want to create that FAQ so we can send it out to participants after. But I want to thank you so much for all of your time and energy you've put into this webinar, as well as to the audience for sticking around and participating today. We greatly appreciate you. In the chat, there is that survey link to complete an evaluation for this webinar. Again, your feedback is appreciated, and you will receive this eval link again in the follow-up email, which will also include information about nursing contact hours and where to send that to, and the paperwork that you will need to fill out for that if you're seeking nursing contact hours. And with that being said, I hope everyone has a great rest of their afternoon and a wonderful rest of their week. And thank you so much for everyone for joining.